Thank you, and good day, everyone. So we've come to the third panel on health emergencies, COVID-19 pandemic, on the action on disaster relief in Africa, the GRV Global Action Disaster Relief Seminar. My name is Robert Kwame Ajaku. I'm the lead advisor for disease outbreaks and epidemics of the African Risk Capacity, a special agency of the African Union. I have with me on the panel Dr. Ahmed Safwat El-Assal, who is the board member and deputy chairman of the Higher Committee of Healthcare Standards, Development and Update of Egypt. That is the General Authority of Healthcare Accreditation and Regulatory in Egypt. Also with me is Amy E. Cunningham, who is the Associate Director for Strategic Operations, Office of HIV and AIDS of USAID, Bureau for Global Health. The third panelist is Dr. Emmanuel Agogo, the Country Director of Resolve to Save Lives, Nigeria. And our fourth panelist, will be Oyeronke Oyebanje, Strategy Coordinator, Analyst of COVAX Strategy Coordination Office, CEPI, which is the Coalition for Epidemic Preparedness Innovations. So we have some 30 minutes to just talk around the topic that we've been given. We have a few questions that have been fielded in. So I will start with the first question, and that will go to Dr. Ahmed. Dr. Ahmed, what are some of the lessons learned from how public health systems across the world, and particularly in Africa, reacted to the COVID-19 pandemic? Thank you.
Thank you, Robert. Thank you, everybody, for letting me to be here with you today. I will go directly to the very good and valid question here, which is talking about the lesson learned. So when we start to talk about lessons learned of COVID-19, we need to think first of what is the real rule of any national authority or any national body at its own country during such a pandemic. Let me go through using my usual way. I will have here 4 boxes. I will start by they have to prevent the illness, prevent the infection. Then they will go to detect and trace any new cases. Then they need to deal with patients, so they have patient care. And then at the last, which is the detecting gaps and fixing them. So if we're starting by the box of prevention, we have learned that we have 4 main ways to deal with COVID-19 prevention. At least these are the sure ones right now, which is the social distancing. We have the hand hygiene, we have using of masks, and we have vaccines. I think those are the only sure 4 ways we have learned till now. So to have these actions done and implemented effectively on the ground, we have to have, and these are the lessons learned, we have to have very well-established people-centered public health system. We have to have robust supply chain because we have things. We have to engage the community and convince them and let them be aware of what they need to do. So we have to have trusted leadership and community engagement. And meanwhile, all the time, while we are saving lives, we need all the time to protect the livelihood. So we have learned that it's not the first solution all the time to have the lockdowns. It's not always the first solution to come. Then we'll come to the next box, which is related to detect and trace the new cases. And here comes the areas of innovation, forecasting, early warning tools. We need to have them all the time. And to have this in place, even before we have the pandemic, we need to establish national and subnational public health emergency centers. This is very important. Then we'll go to the third box here, which is patient care. And when we are talking about patient care, I do not mean at all only COVID-19 patient care, because during dealing with COVID-19 patients, we have other patients, we have surgeries, we have accidents, we have many things. So we need to deal with them all. So we have these three sub boxes, which includes people who are patients who do not need hospitalization. So we need to solve where to take care of them and how to make sure that we are following them all the time, to make sure if they need hospitalization, we have places for them and we can deal with them. Then people or patients who need hospitalization. So whether they need regular care or critical care. And other patients with other cases, like chronic cases, like surgeries, as I've said, like labors and etc. And here we will face the challenges of shortage of staff, equipment, even shortage of spaces available. And here we need surge capacity, and surge capacity should not be just planned and implemented when we have the disaster. It should be planned before the disaster. So we come here to response planning. And this is very important lesson, that we need to plan for the responses before we have the pandemic. And then we come to the fourth box, and it's very important. It's starting from the start step till the end, which is detecting the gaps and fixing them all the time. We need all the time to measure what we are facing and what we are doing, and record them, and then aggregate the data, analyze them, and improve all the time. And during all the journey, please keep keep this closed and transparent. Keep this closed and transparent. Otherwise, you will lose the engagement of your community. They will not trust you. You will lose your credibility. The last point here regarding the lesson learned, actually, till now we believe, and I personally believe, that COVID-19 is not actually the disaster. COVID-19 is just an alarm of what disaster could be if we continue doing the same things, ignoring the lesson learned and expecting different results. Thank you, Robert.
Thank you very much, Dr. Ahmed. Ronke, I would like to come to you with vaccines are now the challenge on the ground. I mean, there's parts of the world have enough, other parts of the world are struggling. I'm one of the millions of Africans and other people in developing countries who is yet to receive a vaccine. So my question to you is, I know COVAX, which you work with and for, has giving out, I think, 30% or thereabouts of its vaccines. What are the challenges that it's facing to, and how is it planning to meet the immediate shortfalls, and what are the long-term plans to ensure that the rest of the world also gets adequate vaccines? Thank you.
Thank you, Robert, and hi everyone. It's a great pleasure to be here again. Like you rightly said, COVAX has indeed faced some challenges this year in terms of delivery, and the surge in cases in South Asia has really had a severe impact on COVAX supply in the second quarter of this year. And by the end of June, now we have about a shortfall of about 190 million doses, which has led to delays in supplies. Now, COVAX recognizes that we have an urgent supply gap, and so we're focused on securing as many shared doses as possible immediately, because the third quarter of this year, from July onwards, is about the period where we see a huge gap between the deliveries that we have to send to countries and countries' ability to absorb doses. And so we've been working with the G7 and other countries that have stepped up to share doses to make sure that this happens as rapidly and as equitably as possible. And the US has stepped up to this challenge as an example. And we hope that with the doses shared through countries like this, we can address our short-term supply constraints and minimize the prospects of higher cases in some regions and even the possibility of spread of deadly variants. Now, thinking about the long term, we anticipate that following the resolve of the current supply challenge, we will have huge supplies to countries later in the year And what COVAX is now really advocating for is for multilateral development banks, funders, and others to support countries, especially low and middle income countries, to prepare their health systems for the large-scale rollout of vaccines that is anticipated to happen later in the year. And so in summary, the main challenge now is with the supply bottlenecks, especially in regions where manufacturing is taking place. But we are pushing for G7 countries and rich countries with higher supplies to give their doses now to meet the existing needs, and for funders like multilateral development banks to start to support countries to prepare their health system for the large amount of doses that are expected later in the year.
Okay, thank you very much. We wish COVAX good luck and success, because that success will mean that I would have a vaccine in my arm. Amy, if I may come to you, I mean, with USAID, you work in multiple countries, so you may have also a practical perspective on some of the learned from public health systems. So if you can share with us what are some of the lessons and how we can take that forward, building on from Ahmed's point. Thank you.
Great, and I'll also build on Ronke's point too. USAID just is really happy to be part of this big effort, tremendous effort, and we're also supporting President Biden's historic step of purchasing 500 million doses of Pfizer vaccine and donating them to countries that need them most, including the 92 advanced market commitment countries, including many of those who are members of the African Union. And I think so underscoring that is cooperation, coordination, and work with multilaterals. So that I think is a very important lesson learned. Some other very practical things from early on, rapidly mobilizing the national task forces and bringing the community in. I think we've seen that countries that have done that very quickly have been able to ramp up fast. As Ahmed mentioned around logistics and supply, we already have existing supply systems for HIV, malaria. We need to use those existing systems for logistics, supply, et cetera. We learned across countries that quickly moving to simplify services was really, really important. For HIV, we're really working on providing multi-months of ARVs. So ideally 6 months for stable patients, 3 months if we can't manage that. And in the case of one country, at least Zambia, and many others are on the same track. Zambia doubled the number of people getting MMD, multi-month dispensing, in a quarter. And that was very early on in the pandemic. For USAID itself, we really took solutions across countries immediately. We held partner solution calls weekly from the beginning. We really ramped up virtual tools, both for communication, but also for training. Use of virtual support for peer support, adherence support, telehealth visits. That has really, really helped move the program along and keep people in treatment, and also averting new infections. We really ratcheted up the use of communication tools such as social media and using community networks, TV, radio, national addresses. We saw that work really well to share and underscore the importance of prevention approaches to really reduce fear. There's a lot of anxiety, and there was early on, there still is now, and now we're in the third wave. That repeated communication really helps, providing info on where to get services, and then also now to address vaccine hesitancy. We're seeing that work well in most countries. Over.
Thank you very much, Amy, for your response. Dr. Agogo, if you would like to bring us to Africa also, in your experience, how has the African health systems been responding? What are some of the lessons from this, and what are some of the challenges from the continent?
Yeah,
from the other side of the continent, because Ahmed is also on the continent, I should say.
Yeah, thank you very much for the opportunity to be here. I think it's quite clear that with regards to response to COVID in Africa, that first of all, the predictions that were made prior to the outbreak, to the pandemic, did not really pan out. And I think that really is a good fortune for the whole of sub-Saharan Africa. Unfortunately, our brothers in the north of Africa, were hard hit at the beginning of the pandemic. With huge deaths in across to North Africa, really, Tunisia, Algeria, Morocco. Across you know, at the moment, like we say, no one really knows the reason why it hasn't panned out the same way. However, there have been significant deaths across the whole of Africa, as we know. Challenges with data systems means that, you know, even the numbers that we report may not be the exact numbers. I mean, this has been the same issue across the whole of Africa. A recent surveillance survey that was done in one of the epicenters in Nigeria showed almost between 1 in 3, 1 in 4 people had been exposed to COVID, even though the numbers that were actually infected did not reflect the same. In terms of Africa's response, we recall quite at the beginning of the pandemic, you know, the panic with when suddenly we all realized that we didn't have the ICUs, we didn't have the access to oxygen, we didn't have the treatment capacity, we didn't have, you know, internists and intensivists who have the experience with intubation and with managing, you know, people with acute respiratory disease syndromes. And unfortunately, there were no quick fixes. You know, there were huge initiatives with buying ventilators, with shipping ventilators. Unfortunately, things didn't really pan out that way. However, you know, the strengths that African countries have had over the years in terms of responding to epidemics, you know, where contact tracing was key to how Lassa fever, Ebola, meningitis and polio have been addressed in the past, were quickly leveraged, and that really helped with response in many countries. Quick introduction of public health social measures way beyond and before cases arrived in many countries also helped with reducing transmission. There were obviously huge problems with getting people to wear face masks and people to adhere to these. You know, Dr. Ahmed spoke a lot about the impact of public health social measures. And the resistance to this was really because of the fact that, you know, the economics didn't really work out for many people who live in sub-Saharan Africa. You know, many are daily wage earners. Many, you know, need to go out on a weekly basis, and the reserves that they have, you know, for many people who live below the poverty line didn't last more than a week or so. And so, you know, the interventions didn't really work out, you know, effectively. The impact of that were quite a few social upheavals across the continent. In Nigeria, we had the massive SARS protests. In South Africa, there were also, you know, a lot of protests when the hospitals were shut down or when people could access treatment. And by and large, I think one of the things that has happened is, you know, people have you know, a lot of the problems and insecurities have made many countries less consistent with managing and, you know, with COVID and with responding to COVID effectively. In talking about the vaccine rollout, I mean, Ronke was very precise with the numbers in terms of how many doses were earmarked for Africa. Initially, the Africa CDC had targeted, you know, played out with various numbers within 20 to 40% of populations to be vaccinated, but those are only numbers because across the continent, you know, the delivery of vaccines has been suboptimal. And unfortunately, our brother Robert has not even been able to access the vaccinations. And recent things that have come up, for instance, a recent pronouncement from EU talking about the Serum India version of the AstraZeneca will also go further to undermine the misinformation that has been there around vaccination and the reason why people have not really been forthcoming with accessing vaccination. So there is, you know, a feeling, I think, around that, you know, largely that the idea of a brother's keeper, which we thought about the global good and how as a global, you know, the response to COVID should be global, the availability of vaccines should be global. And suddenly we're also getting the sense that, you know, even the vaccines are no longer equal. So there's a lot still there's a lot that has been learned in terms of the lack of balance in the social equity, the huge inequalities in global, in the global health infrastructure, and also the huge impact of misinformation and the real gaps in global leadership. I think these have come up very strongly. On the continent, we've been fortunate to have a more cohesive response, and we've had a lot of leadership from the Africa CDC and our country level. However, even within Africa, there are countries where, the politics got in the way of, the response and really impacted on what people felt. Thank you.
I think you're muted, Robert.
Sorry, thank you, Emmanuel. Thank you very much, and all of you. I was saying we're all public and global health practitioners of different forms on this platform, and there's a couple of questions that are coming up I wanted to throw back to you. One is the danger of variants. I mean, we know the Delta variant is now the one that is waging around. What does it mean for us? It looks like even some vaccines may not be as efficacious. That is one. And then there's a question of combining vaccines. Actually, I saw a few publications that shows that that is going to help somehow build immunity than single vaccines. I don't want to say molecular, but Ronke will tell me. So the questions of variants entering into the system and then combining of vaccines. And this is an open conversation. Any of you can take it up. We have some 9 minutes here to chat around other topics. Is that board for the current situation?
If I may jump in, I mean, the issue of variants is very key. We've seen that there's an upsurge of cases in Uganda and East Africa at the moment, just driven by the Delta variant, with the impact in terms of increased mortalities. However, one of the things we need to be clear about is that the rest of Africa doesn't have access to enough genomic testing, so that even establishing whether a new variant is it's in the country, it might be difficult. Although there have been initiatives to set up new genomic testing capacity in a few countries, including Nigeria. And I think that the fact that everybody doesn't have access to vaccination means that those variants will emerge. And unfortunately, it will undermine any investments that have already been made in providing existing vaccines. The lack of research capacity across Africa, also, which is due to not the fault of the West, but also the West of the fault of African countries not being consistent in their planning, means that these gaps will unfortunately remain.
Thank you. Anyone else?
Actually, I want to say something here. May look political more than technical, but it's very important to be said here. Actually, I was avoiding to say that, but it's very important to be said here, because one of the very important lessons which was learned during this COVID-19, that the world is really a very small village, and what's happening in China can affect US, and what's happening in Russia can affect Egypt, and etc. So thinking in a discriminative way between the different continents of the world, that something is not acceptable in Europe, but it can be acceptable for Africa, will not be acceptable. And it will not work, actually. This is the first thing. And I want to build that on the SDGs, the 17 SDGs meeting, which was done in UN, I think 5 years back. It was 6 years back in 2015. And the main slogan was there, leaving no one behind. And really, we want to push toward implementing this slogan. If we are thinking from the equity point of view, whatever is available for Europe and US should be available for Asia, for Africa, and for other countries. This is from the equity point of view. And if we are thinking from the efficiency point of view, believe me, paying for the vaccine is much more efficient than paying for treating the illnesses. And if we are talking about effectiveness of care, that of course the vaccine to reach to the people in the right time is much more effective than start very late after finishing all the countries of all the world, then starting to go for Africa. And I've kept the patient-centeredness or the patient experience till the end, but because it's very important. We have learned something. The main difference between treating people and human being and treating non-human being, for both, we are dealing with the illness and with the pain and with their feelings. We consider the feelings of both human being and non-human being. But with human being, we have learned that treatment should be with dignity. We need to keep the dignity of people. So it's not going with the keeping dignity that we are telling them, okay, this is enough for you, but this is not enough for others. No, we need to have the same rules, the same findings, the same rules to be implemented for all. Thank you.
I want to jump in as well, Robert, on this.
Go ahead.
I completely agree, Dr. Ahmed, everything that you've said. Also, Dr. Emmanuel, I think this is why we need to be supporting Ronke, and we need to be mobilizing as countries that can, all countries in the world. No, for the US, no one is safe, no American is safe until everyone is safe. So I think us doing these kind of global efforts, this is a global public health crisis. And when we see people hurting and suffering anywhere around the world, we need to help as best we can. So I completely agree and support what you say, Dr. Ahmed. I'd also underscore a practical tool element, which is we have massive research capacity in Africa, in India. We need to be taking advantage of these African and Indian institutions, and USAID is doing just that as well. These are groups that have long experience in research for vaccines, as well as many other things. And they really need to be on the cutting edge to get ahead of the epidemic, rather than worrying about catching up now with the variants. So really underscoring use of local institutions and local research capacity. Over.
Okay, thank you. You know, global health is political. Public health is political. You can't take the politics out of what is happening now. Ronke, if would you have something to contribute to this?
Yes, sure, Robert.
Or should I? Yeah, go ahead.
I mean, I'm grateful to Amy and of course to the US government, which she works for the incredible support they have provided to COVAX. And it's a very strong point, because one of the reasons why we've had about 10 to 12 vaccines in development in the COVAX portfolio is that we want to have multiple shots on goal and multiple chances of success. And with the rise in variants, spread in variants, and the possible implications that this could have on vaccines, having a diverse vaccine portfolio as we have developed in COVAX has never been more important. And in addition to the work we are doing with vaccine development, within CEPI and COVAX, we have established a centralized laboratory network with about 8 laboratories across the world and increasing, to make sure that we are testing the impact of variants on the vaccines that we have existing. And so we do recognize that, yes, there is a challenge with variants, there is a risk of their impact on the effectiveness of vaccines, but we are trying to take one step ahead and need continued support of countries, of funders, of philanthropies, manufacturers, etc. to COVAX to make sure that we can do our work of equitable access to vaccines for the world.
Okay. Thank you. I think we have a minute or two. So just from the top of my head, I think the phrase "no one is safe until everyone is safe" is what we should all be promoting now. Personally, I don't think that we are from previous pandemics, from what we're doing with COVID. I mean, the disparity, the inequality is glaring. Some effort is being made, but it's still not where, as a world, we need to be. And as you have also said, we need to be careful where this will take us. We've had the WHO director, we've had the African Union's vaccine envoy, Strive Masiyiwa, the WTO directors. Everyone is clamoring that this is the time for the world to come together. And I think with what is happening, one cannot overemphasize this point. So I would say thank you very much to the panelists and also to the organizers for giving us the opportunity to have this conversation. And we hope that this is added to other conversations around this topic, and that there'll be movement for a global efforts to solve COVID and other pandemics in the future. Thank you.